So, repeatedly asked question, Guillain-Barré syndrome. Okay, so Guillain-Barré syndrome, it's a question which is asked both in pediatrics as well as in medicine. So what's Guillain-Barré syndrome? So Guillain-Barré syndrome is actually a polyradiculopathy. So what is polyradiculopathy? So whenever we talk about, suppose this is your spinal cord, okay? So this is your spinal cord, okay? So what happens is, whenever there is a component which is getting off the spinal cord, so this is known as a radical, okay? So this is known as a radical. Now whenever we talk about this radical, now this radicular component, whenever a lot of these of the radical component are involved, this is known as polyradiculoneuropathy. Polyradiculoneuropathy, okay? Now, so the most important thing that we should understand regarding Guillain-Barré syndrome is it's a polyradicular neuropathy and it's an ascending infection, ascending pattern of weakness. Okay, so first of all, what will happen is the person will not be able to stand, or his weakness will actually start from the feet and it will slowly go up. Okay, in this fashion, that is known as an ascending pattern of weakness. So Guillain-Barré syndrome, it starts with a upper respiratory tract infection. So there is a UTI first of all, and then there is Guillain-Barré syndrome. Okay, first there is a foci of upper respiratory tract infection, and after 3 to 4 weeks there will be a syndrome of weakness. Okay, there is symptoms of weakness. Okay, and remember Guillain-Barré syndrome presents with areflexia. Okay, areflexia. So there are different syndromes associated with the hyperreflexia, upper motor neuron lesion or lower motor neuron lesion. Okay, so you need to understand that this component presents with an areflexia. So there is no reflex which is seen. Okay, it's a component of the muscular weakness, and the most common cause of death is the respiratory compromise. Okay, respiratory compromise is the most common cause of death. Now, what is the actual pathogenesis regarding Guillain-Barré syndrome? The actual pathogenesis behind Guillain-Barré syndrome is the formation of autoantibodies against the myelin sheath of the nerve. Okay, so suppose there is this myelin sheath. Okay, so there is this myelin sheath. Now against this myelin sheath there is a formation of autoantibodies, and this autoantibodies, which is basically being formed against this myelin sheath, will actually lead to demyelination of the nerves, and because of demyelination of the nerves, what happens is weakness starts occurring. Okay, so it's both a sensory as well as a motor component. Both, it's both like sensory as well as motor. Sensory as in there is a areflexia, that is a sensory, and motor, that there is a weakness. Okay, motor, there is a weakness. Okay, sensory, there is a areflexia. Now the most important thing is the treatment. Okay, so the treatment of this one, what you need to understand is you need to understand IVIG. Okay, so you need to understand IVIG. So you have to go for plasmapheresis. Okay, plasmapheresis. IVIG, you have to go for plasmapheresis, and lumbar puncture. If you go for lumbar puncture, you can go for albuminocytologic dissociation. Albuminocytologic dissociation. Okay, albuminocytologic dissociation. The important factor is this one. Okay, albuminocytologic dissociation is the important factor which you see in the case of CSF. In cerebrospinal fluid, what will see? You will see albuminocytologic dissociation. Okay, so the most important thing is there's an increase in the protein level in the CSF. Okay, a protein level in the CSF, it's increased. Okay, that's known as albuminocytologic dissociation. Okay, now the protein level is increased. So what is this albuminocytologic dissociation means? This means that the protein is increased. But what happens is the protein is increased, but the WBC count will be normal. Okay, the protein is increased, but the WBC count is normal. Okay, so I already talked about the upper respiratory tract infection. So upper respiratory tract infection is usually caused by Campylobacter enteritis. So it might be an upper respiratory tract infection, or it might be a gastrointestinal system, or it can also be GI. Okay, but upper respiratory tract symptoms are much more seen compared to the gastrointestinal. Okay, so Campylobacter enteritis, one is Campylobacter enteritis, number one. Number two is cytomegalovirus, and number three is the coronavirus. Okay, so Campylobacter, and then you have cytomegalo, and then you have corona. Okay, so all these viruses are responsible for causing GBS. Okay, so it's like it's a disease of paralysis. Okay, but this paralysis is transient. So if you treat the condition well enough, then that is reversible. It's not like stroke that there will be permanent compromise of the motor function. Okay, so the most important factors are which differentiates it from myasthenia gravis is the autonomic dysfunction that we see in Guillain-Barré syndrome. Okay, so there is autonomic dysfunctions also in Guillain-Barré syndrome. Autonomic dysfunction. So autonomic dysfunction. What autonomic dysfunction will you appreciate? Autonomic dysfunction, there can be arrhythmias, there can be BP, and there will be voiding dysfunction. Okay, so what are you going to do for the diagnosis? You can just go for an albuminocytologic dissociation, where you'll see more amount of proteins and less amount, normal amount of WBC in the case of lumbar puncture. Or you can go for a nerve conduction study, or you can go for an electromyogram, or you can go for an ECG. Okay, so you can go for so you can basically go for a nerve conduction study, or you can go for a nerve conduction study, or you can go for electromyography. Okay, and you can go for ECG. Now, why to see ECG? Because I already talked about the autonomic dysfunction which is basically arrhythmias. Okay, so what do we mean by Miller-Fisher syndrome? Okay, so now let's move on to the slides first of all, and then we will discuss everything. Okay, so frequently severe and fulminant polyradicular neuropathy. The same word you need to write. Okay, polyradicular neuropathy. That is autoimmune in nature. I already talked about the component where there was formation of autoantibodies against this myelin sheath. Okay, so incidence increases by approximately 20% with every 10-year increase in age beyond the first decade of life. More frequently affecting women, more frequently affected than men, more frequently affected than women. So I give you one beautiful story that one of my very very chronic senior. So he had GBS, he had Guillain-Barré syndrome. Because of Guillain-Barré syndrome, he was so much paralyzed to bed. So he had to have a low dose of heparin every time, because as a prophylaxis for deep vein thrombosis, and he became very fat, very very fat. So you can't actually imagine. He went up to 180 170 180 kgs, and slowly he reduced his weight, and now he has a good weight, 85 90, and he has actually reduced a lot of weight, and that's all because of his hard work in the gym. So he has been gymming so far, and he had this condition, right? So it was so compromised that he had to go for an ET intubation because of severe respiratory distress, but he is well known now. He's also a doctor. Okay, so it's regional variation. So axonal forms being more common in Asia, North America, Europe, demyelinating forms predominant. Okay, now it's an autoimmune disease, so both cellular and humoral immunity is basically involved. There's T cell activation, interleukin 2 receptors, interleukin 6, TNF alpha, interferon gamma. So whenever we talk about macrophages, basically macrophages is always associated with interferon gamma, right? Interferon gamma. You remember the recruitment of macrophages, which was done in tuberculosis, is also secondary to interferon gamma, right? So the same mechanism is over here also. So GBS results from immune responses to non-self antigens, infectious agents, vaccines that misdirect to host nerve tissues through a resemblance of the epitope. Okay, now so this is actually complex mechanism. So basically we have two units. So one N-acetyl neuraminic acid and N-acetyl glycosamine, right? So these are actually connected with the pentaglycine bridge. If you have remembered, when we studied mechanism action of penicillin, we studied the same thing, right? And this basically cellular structure is being shown over here. Demyelinations thing, we don't need to go into core details. The most important thing is there is demyelination, complement activation, and nerve injuries. Okay, secondary to macrophages. So I already told you certain virus like Epstein-Barr virus, cytomegalovirus virus, Zika virus, okay, Campylobacter jejuni. So these are the most important factors responsible for causing infections in the respiratory or the GIT. The more important being the respiratory. Okay, so recent immunization, just rule out recent immunization secondary to swine influenza vaccine, older rabies vaccine can be seen in patients with lymphoma and HIV and AIDS. Okay, now remember one very very important thing, that never give corticosteroids never give corticosteroids in the case of GBS. Okay, so GBS, never to give corticosteroids. Okay, so respiratory or GI tract infection prior to onset of illness, around 3 weeks. issue of recent immunization, I already talked about the immunization that we have to talk about. Okay, so a recent immunization. So a recent immunization, or basically Epstein-Barr virus, cytomegalovirus, Zika virus, right? And sudden or progressive weakness over 2 to 3 days, and that weakness is an ascending pattern of weakness. Okay, never to miss this ascending pattern of weakness. No fever at the onset of weakness. Fever and constitutional symptoms are absent at the onset if present. Case doubt on diagnosis. Okay, so that means we are not expecting, we are not expecting fever. We are not expecting fever during the course of illness. Of course, during basically whenever you had an upper respiratory tract infection or a gastrointestinal symptom, there might be mild grade of fever because it's a secondary to viral disorder, right? It's a viral disease. Okay, but the most important thing when it comes to Guillain-Barré syndrome is fever is not the most common presentation. The most common presentation being polyradical neuropathy, which is basically weakness, because of polyradical neuropathy is ascending weakness. Okay, so motor system, and then you have the deep tenderness. So the deep tenderness is, just remember areflexia. You don't need to remember everything. Just remember areflexia. So reflexes at birth then disappear in few days or off onset. Just remember not to write all of this. Just remember there is areflexia. There is areflexia. Okay. So there's an involvement of cranial nerves also, and which leads to weakness of the cranial nerves. Usually there's sparing of the ophthalmic nerve, but what happens is whenever there is a component which is known as Miller-Fisher syndrome. So Miller-Fisher syndrome is one type of Guillain-Barré syndrome where your this basically your okay, where your eye manifestation is seen. Okay, is seen over here in Miller-Fisher syndrome. Okay, now ascending type of paralysis, weakness involving in evolves over hour to days. Legs are more frequently affected at the onset. Tingling, dysthesis of the extremities. So it's also known as stock and glove. Okay, stocking and gloves type of paresthesia. Okay, next is ascending paralysis, weakness involving hours to days. Okay, legs are more frequently involved. Cranial nerves, so facial diaparesis seen in 50% of the affected individuals. Most commonly the face is involved. Yes, ophthalmoplegia, I told you, in Miller-Fisher syndrome it's affecting the ophthalmic nerve also. Okay, but others now, lower cranial nerves are affected. Bulbar weakness, difficulty in handling secretions and maintaining patent airway. So of course whenever we talk about cranial nerves are involved in a lot of cases, but the major one being facial paresthesia. So facial diaparesis, and they might present with features of Bell's palsy also. Okay, sensory system, large myelinating fibers are more severely affected. Proprioception affected more than pain, temperature, sensation. So basically already we talked about the sensory stimulus is lost. I already told in my first slide that both there is sensory also there is loss, and motor also there is loss of sensation of both of the factors. Sensory is also lost, motor is also lost. So what happens when there is a loss of both of the sensory as well as the motor component? So it's a mixed type of variant, isn't it? So it's a mixed type of variant. So next, so bladder. So I already told about the autonomic features of Guillain-Barré syndrome, right? So there is autonomic feature which is seen secondary to Guillain-Barré syndrome, and autonomic feature which is seen secondary to Guillain-Barré syndrome makes our diagnosis towards ECG. So we have to also go for an ECG to look for certain arrhythmic patterns which we can appreciate in the ECG. And the most important factor is, suppose there's a weakness and we have to rule out the bladder dysfunction. Okay, so there might be voiding disturbances. Okay, affected only in severe cases and is usually transient. If a prominent features or comes early in course, think for alternative diagnosis, usually spinal cord disease. So late in onset is bladder, no fever, albuminocytologic dissociation, ascending paralysis. That is Guillain-Barré syndrome. Now pain over the neck, shoulder, back and diffuse over the spine, present in 50% of the cases at the time of onset. Diastatic pain in extremities, self-limiting and respond to analgesics. So basically there will be pain. Okay, so the paresthesia tingling sensation, the glove and stocking tingling sensation, which is basically appreciated, right? So this is also followed by pain. Okay, so there's pain on the neck, shoulder, back, diffuse over the spine, present in 50% of the cases at the onset. And there's the pain in the extremities. So it's self-limited and responds to and biotics. So I already told about the autonomic involvement. Please be thorough with autonomic involvement. Okay, autonomic involvement, but because myasthenia will never have autonomic involvement. Okay, myasthenia will not have autonomic involvement, but but remember, myasthenia will not have autonomic involvement, but Guillain-Barré syndrome will have autonomic involvement. Okay, so it's common, can be present even in mild cases, while fluctuation in blood pressure. Okay, while there is wild fluctuation in blood pressure, there's postural hypertension, cardiac dysarrhythmias, as they can be overlooked. Close monitoring and management can be fatal. Okay, so basically BP fluctuation and cardiac dysarrhythmias must be remembered. Okay, so if in case hospitalization needed, that means there's a respiratory compromise, and because of which there is hospitalization needed. Okay, so this is basically the differential diagnosis for Guillain-Barré syndrome. So you can remember diphtheria, tetanus, botulism, right? Myelopathy, acute myelopathy, porphyria, poliomyelitis, myasthenia gravis, OP poisoning, brainstem ischemia. Okay, so I think you will not forget. Okay, I think you will not forget botulinum. Most important being botulinum. Okay, diphtheria. You'll not forget because diphtheria also, it has, like the cardiac arrhythmias can be seen with diphtheria. There will be weakness, okay, numbness, right? And poliomyelitis, myasthenia gravis, brainstem ischemia, OP poisoning. You'll not miss it. You'll not miss acute myelopathy. Okay, acute myelopathy. Okay, now let's talk about some different variants of this Guillain-Barré syndrome. So this is an acute inflammatory demyelinating polyneuropathy. Okay, acute inflammatory demyelinating polyneuropathy. Remember, A for acute, A for adults. So adults are more commonly affected than children. Demyelinating pattern on electrodiagnosis. So whenever we go for an electrodiagnosis, then we can see that demyelinating pattern. Okay, so anti-GM1. You have to remember this. Okay, GM1, General Manager 1. Okay, just a joke in between. Anti-GM1 antibodies are seen in about 50% of the cases. There is rapid recovery. First attack on squamous cells with widespread myelin damage with macrophage activation and lymphocytic infiltration. Variable secondary axonal damage. Okay. So next is AMAN. AMAN is very, very important. Okay, acute motor axonal neuropathy. So I talked about acute inflammatory demyelinating polyneuropathy. So this IDP, it's very, very, I've heard about this IDP, I think in pediatrics. IDP in pediatrics, I have to look into it. IDP pediatrics. So from that, I think we'll be able to International Development of Pediatric Association. Yes, IDP. International Development of Pediatrics is IDP. So you know that IDP along with A. Okay, so acute inflammatory demyelinating polyneuropathy. Okay, so AMAN is acute motor axonal neuropathy. Acute motor axonal neuropathy. So acute motor axonal neuropathy, so usually affects children and young adults. Okay, so axonal pattern of electrodiagnosis. First attack on motor nodes of Ranvier, macrophage activation damage to the axons, and anti-GM1 and anti-GD1A autoantibodies. So GM1 is seen in both. Rapid recovery. Okay, so remember, acute motor axonal neuropathy, acute inflammatory demyelinating polyneuropathy, and MSAN is also, there's one, acute motor sensory axonal neuropathy, MSAN. Okay, MSAN. Miller-Fisher variant. So triad of ophthalmoplegia, areflexia and ataxia. This you have to write. You have to write ophthalmoplegia, ataxia and areflexia. Okay, now lab diagnosis. Albumin-cytologic dissociation, what does that mean? There is more amount of protein but less amount of WBC. Okay, so WBC is normal basically, not less. CSF is more often normal. When symptoms have been present for less than 48 hours, the level of protein is usually elevated by the end of first week. Okay, elevated CSF protein level. Okay, without accompanying pleocytosis. Now, electrodiagnostic test. For very long slides, no? Okay, so we'll continue from this in the next video.